and I'm here associated with SCORE to help you prepare for your NEET MDS exam in orthodontics department. And yesterday we discussed about anchorage and different types of anchorage and what is absolute anchorage and all the MCQs associated with it. Today we are going to discuss about anchorage, the absolute anchorage part, followed by habits. And let's hope to cover 50 questions today. So stay tuned to the class. Yes. Hope I'm audible and you can see the screen with that information. I'm continuing the session. So today we'll start with this question. True for failure or success of mini screws. So they've asked us to identify which of the following statement is true regarding either the failure or success. So failure more in self-drilling than pre-drilled. Okay? Self-tapping or self-drilling difference should be known in this scenario. Success is directly proportional to the force. So more force, more success. Mini screw failure is more in mandible. Success is more in female. So the last option would not be true. And self-drilling versus self-tapping, the scenario is entirely different. So which is very true. Since we eliminated two options, the remaining option is force and then mandible. So obviously, when you give more force than necessary, it will break and result in instability. So the answer will be so the failure is more in mandible. Why? Because in mandible the bone thickness is high, and thereby the success rate or the um, giving up of implants in the mandible is the stability is pretty low. So there are several factors which is associated with it, which includes the type of implant, insertion technique, bone quality, and also associated with the patients. So some of the important facts that you have to take up home from this MCQ is that failure rate of TAD is higher in mandible when compared to maxilla because of high density of cortical bone and a thinner layer of the cancellous bone, which makes it more difficult for the TAD to attain its primary stability. And also based on insertion technique, as I already mentioned, self-drilling. There is something called self-drilling or self-tapping. Okay, we have to understand the difference between them. So self-drilling process can cause damage to the bone and compromise the stability of the implant as well. Okay, done. So yes, and the TAT success is not directly proportional to the force because the more the force, the better TAT insertion happens is really a myth. We have to give optimal force for the TAT to stay for a longer period of time and attain its primary stability. So patient-related factors such as age, sex, and systematic health also plays a major role. Excuse me, 1 minute. Yes. Sorry for the disturbance. So proper patient selection and careful placement technique also involves in the primary stability of the TAT. So as we discussed, the successful TAT placement is more in maxilla when compared to the mandible, and it involves lots of factors like patient selection, patient systematic conditions associated with it, insertion techniques, and much more. Coming to the next question, optimum recommended maximum torque for the stability of the minimum screws. Okay, torque is nothing but the force elicited by the implant during the process of retraction. Okay, so what will be the optimum force level? So usually it will be around 5 to 10 nano per centimeter because usually the TADs are absolute anchorage system. That is, there won't be any loss of anchorage when we use TADs. That is the given scenario. And by achieving a proper stability by careful selection of the implant design and insertion technique, the torque is applied during the insertion. Okay? The important facts to be looked here is that so the maximum optimum torque range is given as 5 to 10 Newton per centimeter. And applying too much torque can also result in destruction of the bone or surrounding area, so which may compromise the stability of the tap. So applying little torque also can result in inappropriate or inadequate primary stability and thereby results in the TAT failure. So always you should provide an optimum torque value. What factors will affect torque? Implant design, which bone it is given to, that is maxilla or mandible, so bone density levels, insertion sites, and also the operator experience. These four things comes under the factors which affects the optimum torque for tats. Okay. So, in addition to torque, there are many factors like insertion angle, depth, and placement side. You remember yesterday we were discussing about what are the threads, what is called the pitch and helix angle, right? So, and what is the optimum diameter used for a tag. So, in addition to that, you should know about self drilling and self tapping mechanism insertion techniques, and also more about the material which is involved in the making of tags and associated with torque, insertion angle, and depth. When you have good knowledge about all these factors associated with that, I think you can answer more than 10 questions when it comes to that. Going to the next question. So, which of the following does not increase the primary stability of the microscrew? So, we are only discussing about which factors matter to increase the stability of an implant or a microscrew, right? So, the first one is cortical bone thickness, spongy bone thickness, length, diameter, shape, and pitch. Operator technique using cortical pre-drilling. So, it covers almost all the factors involving the screw material and the bone. So the question is not. You should always understand the word. Whenever they've given not, you should pay important attention to it. So I feel operated technique using cortical pre-drilling. Yes, that is the answer for this question. Why? Because when comparing to the other answer given here, this is in a different set of scenario. And the primary stability is a critical factor, right, in the success of an implant. The primary stability mostly depends on the material of the TAD design and also in the bone which is it going into, rather than the operated technique. It is also an important factor, but it doesn't only govern the primary stability of the TAD. And some facts associated with this question is that cortical bone thickness is the most important factor. And because the cortical bone, it provides resistance to the implant movement and thereby increasing the implant stability. Spongy bone, on the other hand, is another crucial factor in the primary stability. A thicker layer of spongy bone can provide better anchorage for the implant and thereby increasing the stability. So, bone quality measuring is always important when identifying the area to place the tag. And also intrinsic factor of the tag, its length, diameter, shape, pitch, helix angle, and also its insertion angle, or some other essential factors, the primary stability. A large diameter and longer implant means more surface area which is utilized for it for providing the stability. Operated technique using cortical pre-drilling actually can improve the primary stability by reducing the amount of force which is required to insert an implant. But it won't be the major reason for primary stability. It may be an adjunct to it. Okay? So, in summary, all the factors that I've mentioned aid in primary stability, operated technique being the least of them. Okay. Though pre-drilling can reduce the risk of damage to the surrounding bone, it does not directly contribute to the primary stability. Okay, you understood about the factors involving in both torque of the TAT and also the stability of the TAT, right? Going on. TAT or the mini screw used in orthodontics can withstand forces up to. So this is a very important question and it can be repeated also for a lot of time. It's 500 grams. So up to 500 grams, it can withstand the forces. Only when it is greater than 500, then the failure of TAT occurs. Now we'll see how they can the ability of the tire to withstand forces. It is directly proportional to its stability, right? More is the ability to withstand forces. So the stability, as we discussed, is depending on number of factors, which includes particle bone thickness and also the implant design and insertion techniques, right? So the maximum force also depends on factors like implant length, diameter, location, as well as patient's age, sex, and bone density. So these are all the factors that we already discussed. So in summary, what they have mentioned is that TAT stability and force all depend on a lot of factors, and it has been studied under a wide range of values. But always imagine that TAT's maximum force is up to 500 grams. With introduction of TAT, most significant changes in envelope of discrepancy has occurred. So you all knows envelope of discrepancy, right? It is nothing but the maximum range and a tooth movement can happen in three dimension of space. That is an anterior, posterior, vertical, or transverse. So they have given an envelope of discrepancy. So within which we can move the tooth. Okay. So this is the concept behind it. So with the introduction of TAT, so TAT is nothing but an absolute anchorage. So whatever we could achieve using an orthodontic principle, TAT would be more. If, for example, if in orthodontics the anterior tooth movement can be brought up to 5 mm, a TAT can be brought up to 7 or 8 mm. So always it will be more than what an orthodontic principle can achieve. With that in mind, let us go to the question. Reduction of severe overjet, intrusion of molars, extrusion of incisors to close the open bite, auto rotation of mandible with intrusion of buccal segment. So given the fact that TAT is an absolute anchorage and it can do a lot of things above and beyond the orthodontic principles, we can go for the option auto rotation of mandible with intrusion of buccal segments. Yes. But if this option is not given, intrusion of molars is also more possible. So here we have to identify the best possible reason for the given question. All of it may be right, but we have to always choose the best answer for the given question. Yes. So auto rotation of mandible with intrusion of buccal segment is a significant change that can be achieved only with the use of TAPs. Intrusion of molars is also difficult. Okay, this auto rotation and intrusion will be difficult when we are practicing only with orthodontic mechano principles or biomechanics. When a TAT is incorporated, it happens, but it is way more easier, and the results are predictable, and the direction which is acceptable. So, in option A, they've given reduction of severe overjet. Another common orthodontic problem that can be corrected using TATs. They also provide an anchorage point for anterior teeth, allowing for controlled retraction of these teeth in translation manner. This can help to reduce the overjet and improve the patient's bite. So overjet correction need not necessarily include that. They can also be done orthodontically, but beyond the envelope of discrepancy, that is the key word here. The options auto rotation of mandible makes a better sense. So here extrusion of incisors to close the open bite, right? It's not typically achieved because generally we want the tooth to extrude, right? If at all it is necessary to use a TAD, then we use TAD in the between the lower incisors and the canine region on both sides. It is a rarely used scenario in order to achieve an incisor extrusion. Okay, I think some of you have given some questions in chat box. Let me address that. Okay, so you have asked me when we will give TAT and in what condition. So for you to understand this, you have to understand the envelope of discrepancy. When you feel that you can correct the patient's malocclusion within the envelope of discrepancy offered by the orthodontic treatment, then you need not go for TAT. Only when you need to go above and beyond and you don't want any skeletal, a surgical involvement with the patient, then you can go for TATs. TATs is generally used for um, cases which require absolute anchorage, that is no loss of anchorage, so complete anterior retraction to cover the extraction space closure, right? Those conditions we can use TADs. We can also use TADs in case of a deep bite correction in order to intrude the whole maxillary condition, or we can intrude the molar as such separately. So using TADs will help us in having a predictable movement, direction, and also in achieving the necessary result. But it will always fall in the envelope of discrepancy. So, as your question is, when will we give TAD in what conditions? It depends on your patient. And your patient requires a reduction in overjet of say 6 mm. It will fall into the envelope of discrepancy, which can be achieved by orthodontic principles itself without using TAD. But when the overjet required to close is 9 mm, then you can use an adjunct, which is TAD. I think I've answered your question. Let's move on. So coming to the summary, the most significant changes that can be achieved with the use of TADs or auto rotation. So as I said, it is the significant change. All the other conditions are also possible, but this is the most significant one. Okay. So just to summarize, we've learned more about TADs, how TADs are placed, what are the important factors associated with primary stability of TADs, and uh, where it is more stable and in which conditions it is more stable, and what are the important parameters of an individual implant design, and also which is better, right? So we've seen all about the TADS quality. Now coming to the material. Resistance to corrosion of titanium and its alloy have the main advantage. The corrosive resistance is due to the formation of which of the following? So corrosion means it is the material is being corroded by the presence of oxygen in the atmosphere reacting with the material, right? So whenever there is a oxide layer formed on the top, then the corrosion doesn't happen. So here usually the answer is titanium oxide. Yeah. So the corrosive resistance is due to the formation. The resistance layer is because of titanium oxide. Just understand like this. Mainly, titanium is used in a lot of industry nowadays, and especially in dentistry, because it is corrosive resistance, right? Even when it comes in contact with bodily fluids or used for a long period of time. Um, the titanium oxide is an inert and a non-toxic material which doesn't react with the surrounding environment and also acts as a protective barrier. So always think of this in mind. Titanium oxide is important for corrosion resistance. And this, on the surface of titanium, it allows naturally in the presence of oxygen, water, and other substances. Okay. Option B is the correct answer, that is titanium oxide, and it provides excellent corrosive resistance when compared to other things like carbon, nitrogen, or hydroxide. So moving to the next question. Alloy element in medium grade 5 titanium alloy acting as alpha stabilizing agent is. So in this question, we need to find out the alloy element. Okay. So what is the keyword here? Alpha stabilizing agent. So first we need to know what is alpha stabilizing agent. Alpha stabilizing agent is nothing but in a particular room temperature, what is the ductility element? What is the ductility material of the element used? Okay. So it should be malleable and ductile in the room temperature. That is called alpha stabilizing agent. And I feel here the answer is aluminum. So, as I already said, titanium alloys are used in various industries, right? And usually they also have titanium oxide as a corrosive resistant substance available. So, this alpha phase is a low temperature phase that is stable in the room temperature. Whereas alpha phase is stable at room temperature, beta phase is high temperature that is stable at elevated temperature. And it provides good strength and hardness. So, we have two phases, one is alpha and one is beta. Beta is high temperature, it provides high strength. Alpha is room temperature and provides ductility, that is malleability. We can work with it. So in a medium grade, grade 5 titanium alloy, aluminum is the alpha stabilizing agent. So it is added to it so that at room temperature we can move the wire or we can make shapes based on that. It is also helpful in the corrosive resistance aspect. Other options they have given is carbon, vanadium, molybdenum. They're also commonly used. So we can find out which element is useful for what. For example, carbon is added to increase the wear resistance and hardness. So as we all know, carbon is for hardness, right? Vanadium and molybdenum, they are added to increase the strength and creep resistance. Molybdenum, always remember, associate with creep resistance, and therefore aluminum is mainly used in an alpha stabilizing stage, that is for ductility improvement, right? Just keep this in mind. Which element is used for what purpose? Coming to the next question. In the following case of elastic ribbon is used to retract the upper anterior teeth with cortical device as anchorage. Which type of anchorage is it? So basically they've given the answer. Cortical anchorage. What do you mean by cortical anchorage? It is between the bone. When the implant is placed between the bone, then the cortical anchorage will be giving us the anchorage required. So here they've given the scenario of an elastic ribbon spring, right, to retract the upper anterior teeth. So it cannot be stationary anchorage because it is associated with bodily movement, we discussed earlier. It cannot be reinforced anchorage because it is associated with the tissue and the surrounding elements of the tooth. It can either be absolute or cortical. Since cortical anchorage is not the only scenario here, we are associated it with the spring. So answer is absolute anchorage. Yes. So we've already classified anchorage into different types, right? So stationary, absolute, reinforced, and cortical anchorage. Here, the elastic spring is used to retract the upper anterior teeth with cortical device as an anchorage. What is a cortical device? It is a type of anchorage which utilizes the bone as an anchor for orthodontic forces. So the TARS use the cortical bone as a site with which it provides the anchorage element. So the continuous force is being applied to retract the upper anterior teeth to the tat which is associated with the cortex. So it is an absolute anchorage. The correct answer. The use of cortical device as an anchorage for elastic ribbon indicates absolute anchorage is being employed to ensure upper anterior teeth are effectively retracted without any unwanted movement. So as we discussed earlier. So done. So with this, we've covered everything with respect to anchorage. What are the different types of it and how it is classified? And we have an in-depth explanation on TADS. What are its basic factors for primary stability? What are its designs? And which material are used in it? And how it is important? And what are all the factors which affects uh, its stability, everything we've seen. So keep in mind whenever you're answering a question, think of all these things before you do. Okay. Coming to habits. So Ernst Klein has classified habits into. So they've given so many classification. You need to understand a lot of classification to find out who gave what and classified into what categories. Here, it's given compulsive and non-compulsive, intentional, non-intentional, primary, secondary, and pressure and non-pressure. So each person has given different classification. Here, the answer is intentional and non-intentional. So remember, Ernst Klein has given intentional and non-intentional. So for that, we need to understand what is intentional and non-intentional. So intentional is something that we are very conscious about to do it anyway, like toothbrushing. Non-intentional is it is a side effect of a certain emotion associated with it, like nail biting or biting of the clothes, such items. So intentional is always bringing out the positive outcome, but non-intentional is associated with an emotional withdrawal or trauma, so it is always associated with the negative items. Yeah, as I said here. So yeah, non-intentional habits may lead to negative outcome such as health problems, addiction, and decreased productivity. So both the intentional and non-intentional can be influenced by a lot of external factors. They can do whatever the other person is doing, and then it can build up into either an intentional or a non-intentional habit. So we need to understand the difference between them, which will help according to Pinkham, which of the following is the fourth dimension of the habit? So the emotion that they get when they do the habit, that is the fourth dimension. There is nothing but what, why, how, and when. So this is the why. The first dimension is the frequency. Frequency is number of times they are repeating the habit. Intensity is the level of vigor with which they are repeating the habit. That is duration, for how many times or what is the duration of the habit that is taking place with a particular person. So these are all the important aspects when it comes to identifying the four dimensions of the habit. Thumb sucking. Thumb sucking always produces maxillary pragmatism, always indicates psychological disturbance, always needs appliance therapy to break the habit. None of the above, many times it stops simultaneously or spontaneously. So here we have to understand thumb sucking will. They've not told about prolonged thumb sucking or problematic thumb sucking. They've just given thumb sucking. So always our mind usually goes to always produce maxillary pragmatism, right? It is wrong. So they've just given a general aspect. So I think the answer is none of the above. Many times it's what? Spontaneously. Yes. Because thumb sucking may not always produce it. We have to always be very keen on what are the words which is used in the question, rather than directly going okay from thumb sucking to maxillary prognathysm. No, don't do that. Always be very careful in reading the question. So it may not always be a psychological disturbance, or it may not always require an appliance therapy to break it, but instead it can also stop on its own. It is a common habit, and generally it stops around the period of 4 ages. And prolonged thumb sucking may cause severe side effects, but generally it stops by 4. And sometimes it may also indicate psychological distress, such as extreme anxiety or insecurity kind of thing. And the treatment can include positive reinforcement, that is, giving a gift or giving something rewarding to the patient so that they don't continue with the habit, or sometimes appliance therapy can also be used. So in thumb sucking is a spontaneously reducing event, and if not, then we can succumb them to an appliance therapy, or we can succumb them to any positive reinforcement. But we have to wait till the age of 4. The age up to which thumb sucking is acceptable. Just now we discussed, and that's obviously 3 to 4 years. Yes. So according to American Dental Association, thumb sucking generally acceptable up to the age of 3 to 4 years. So here, a lot of questions will be very. You should always remember the range rather than a particular value, because a lot of different association would have come about with different scenarios. So whenever they are very particular in the question, go with the range. Okay, done. The oral drive theory to explain thumb sucking habit was given by. So as I already said, you should know which person gave which classification and which theories. It's very important when it comes to habit. So here the answer is Sears and Weiss. Oral drive theory. So let us see what is oral drive theory. So it just explains that the thumb sucking habit, which is proposed by Sears, William Sears, and Martha Sears in their book, The Baby Book. So basically, in the oral drive theory, they have an innate drive to suck. Okay, the primary goal in their life is to suck only, which is a very natural way, because according to them, their body needs nutrition and it's only be attained using the sucking feature. So that is this oral drive. They are driven by their mouth. Okay? That is what the oral drive theory suggests, and it's given by William Sears and Martha Sears. So while thumb sucking is a common behavior among infants, it's important to note the direction and the duration of the particular event to identify with the problem. In summary, Sears' theory, they explain that the thumb sucking pattern is a natural and necessary behavior, right, which can persist beyond the need for nutrition and comfort. So they are saying that when a child is not experiencing proper nutrition or comfort, then they can extend their thumb sucking habit. So if their needs are met, then it will reduce on its own. Routing reflex. So here you can find the pattern of questions. When it comes to habit, initially they are talking about who gave what and who gave which theory, but then later they're routing towards the clinical aspects of it. So we've seen about oral drive, and now we are looking at routing reflex. So routing reflex is nothing in a newborn child, right? Whenever you keep a finger in its cheek, it will automatically try to move its mouth towards the point of contact. So that is the routing reflex. So when does it disappear in normal infants? By the age of 7 months after birth. Always remember, 7 months after birth. So it is a reflexive response in the newborn, which involves turning their head towards a particular stimulus. It can be anything. So this routing reflex usually disappears around 7 months. Sometimes it can be up and down. And they also learn to control their head movements and feeding behavior, and then the routing reflex is no longer necessary. The disappearance of routing reflex varies from one person to another. It can be because of supermaturity or poor maturity or delayed maturity as well. So usually it disappears by 7 months, and they should monitor the infant's development and reflexes to ensure that they are meeting their milestone as appropriately. Then, after routing reflex, we have the sucking reflex and infantile swallow, which normally disappear by at what age it will disappear. So, by the first year. You know what sucking reflexes? They are essential for feeding the newborn infants. It involves the rhythmic movement of the mouth and the tongue to extract the milk from the nipples. So, that is the reflex that they basically need in order to survive their first year. So, this will disappear after the first year of birth. Um, They develop new feeding skills and patterns, which include the ability to eat solid food and drink from the cup. So, as they decrease these reflexes, they increase the other methods in order to obtain the nutritious food that they deserve. So, it is very important to consider the disappearance of these reflexes can vary from one person to another. It depends on a lot of factors, but generally, it disappears in the particular age. Okay, according to Sutton Lee et al., the group of thumb sucking in which thumb do not contact with lower incisor is. So Sutton Lee has given a diagram. Okay, basically at which level the thumb is placed inside the mouth in order for the patient to undergo that problem. For example, each patient does thumb sucking differently. For some people will keep it on the edge of the incisor, some will go to the cingulum, and some will have the entire thumb into the palate, right? So he has graded these thumb sucking into 4 types. And in this, what he has given is thumb sucking in which thumb do not contact with the lower incisor. So that is group 3. Now let us discuss in what classification he has given. So yeah. So in group 3, the thumb sucking is defined as a habit in which the thumb is placed in the mouth but doesn't contact the lower incisors. In group 1, the thumb is in constant contact with the lower incisors. But in group 2, the thumb is in contact with the upper incisors. Okay. So in group 3, that is the question wherein they do not have any contact with the lower incisors, but in group 1 and 2, they do have contact. In group 3 thumb sucking, it may lead to some dental problems over time because of continuous pressing against the palate. It may lead to increased overjet and also proclinations. Group 3 thumb sucking is defined as a habit in which thumb is placed in the mouth but doesn't have contact with the lower incisors. Next question is, a 13-year-old child has severe thumb sucking habit. On examination, he has class 2 malocclusion, anterior open bite with an overjet of 12 mm. That is, it is forward so much and is 13-year-old, so he is still in the growth phase. His cephalogram will show normal anterior and posterior facial height, increased anterior facial height, and normal posterior facial height. So basically, since he has severe thumb sucking, right, his jaw would have gone down. That's why he has an open bite. When the jaw is going down, his anterior facial height would obviously be increased, and his posterior facial height will be normal. That is what the question is. So, in order to understand that, we need to know what a ceph is. Ceph is a two-dimensional image of a three-dimensional object, okay, which will help in understanding the position of a skeletal bones with respect to the profile. And when it is a 13-year-old child, we can also identify from a cervical vertebrae that whether his growth status is complete or not complete. And it will also show the measurement value of maxilla, how much mandible is there, and how it is rotated, the mandible downward or upward, and what are the different values which can be obtained from the cell. So why here there is a downward rotation of the mandible? Because he has constantly kept his finger in the mouth, right? So obviously it has created an open bite in the anterior region, which has forced the mandible to go down and thereby increasing the anterior facial height and maintaining the posterior facial height. And Ceph is just one tool. We can't always rely on Ceph to get values. There are a lot of other tools in which we confirm the diagnosis. So in summary, so here with severe thumb sucking habit will likely to show an increased anterior facial height and a normal posterior facial height because of the presence of suction of the thumb on the upper front tooth, thereby increasing the overjet as well. So thumb sucking profile includes a convex and a long face, concave and a short face, convex and a short face, and concave and long face. So just now we discussed that it is long face, so long anterior facial height, and thereby the answer would be convex and long face. Yes. Usually, thumb sucking is convex in long face because of downward rotation of mandible while we are keeping our thumb inside your upper jaw, which in turn will increase the lower anterior facial height and thereby making our face long, and our chin will go back and therefore making it convex. Sometimes patients with thumb sucking may also have a concave profile and a short overall face length and a more balanced facial proportion. This can also happen. It's not more common, but it can also happen. Um, It is important to note, while a convex and long face is a common thumb sucking profile, it will always not present by itself, because if sometimes the patient has a strong mandible and he has a growth potential for the mandible to come forward. So even while thumb sucking, the mandible will grow forward direction. It won't go downward. So in those scenarios, the patient will present differently. So it is not always convex and long face, but it is most commonly associated with thumb sucking. Prolonged thumb sucking directly results in all of the following. So the keyword is except. So they've given except this, it is associated with all other things, right? So either deep overbite, proclination of upper central incisor, it is a possibility, rotation of upper laterals, and constriction of maxilla. So constriction of maxilla obviously happens because there's suction in the anterior aspect. Proclination happens because of which deep overbite happens. So here deep overbite is does not directly result from prolonged thumb sucking, okay, because when they are having their finger into the mouth, obviously there is a space between their upper and the lower anteriors, right? So deep bite would not result. Yes, always it results in the proclination of the upper central incisors, which will in turn lead to the rotation of upper laterals and thereby constrict the maxilla. But it won't give rise to the deep bite because always there is a finger which is preventing the upper and lower jaws to meet each other. So deep overbite is not a direct result of prolonged thumb sucking. A deep overbite occurs when an upper front teeth overlaps significantly with lower front teeth and thereby causing the deep bite. Like the upper front teeth is so much more in advance that it completely closes the bite, though it is not in contact with the lower incisor. Such cases deep bite may occur, but usually it is not directly associated with thumb sucking. It also involves a skeletal factor to it. So, in the last MCQ, I think we are very much aware of what are the effects of thumb sucking on the intraoral aspect. One is constriction of maxilla, proclination of incisors, rotation of lateral to a certain extent, and deep bite only when a skeletal pattern is involved. Otherwise, the out of the equation here is deep bite. Coming to the next question, posterior crossbite is a clinical finding in children with crossbite is something wherein the maxilla and mandible are coexisting with a particular occlusion. When the mandible supersedes the maxilla or the maxilla completely supersedes the mandible, then it will lead to a crossbite. Okay? The bite which is not proper with each other leads to crossbite. So, what is the reason when there is a crossbite? It may be a prolonged sucking habit, a tongue thrusting habit, mouth breathing, or as enlarged mandible. So it is a prolonged sucking. So when the patient continuously has a sucking habit, then it may result in the crossbite because the mandible may go in and the maxilla may come out, or vice versa may happen. So generally it is a malocclusion where the top back teeth, that is the posterior teeth inside the bottom back teeth instead of outside. Generally the maxillary teeth, as I already mentioned, right? If this is the maxillary molar and that is the mandibular molar, they're not like this. Instead they are like this. The maxilla is slightly outside and the mandible is slightly inside. So crossbite is a condition wherein the mandible is slightly outside and the maxilla is inside. This is crossbite. And we've understood now that crossbites usually occur in association with thumb sucking. One of the most common causes is prolonged sucking habit, particularly thumb sucking. Why this happens? Because as we already seen, constriction of maxilla happens. Because of which the maxilla is constricted, it is coming in and the mandible is outside, thereby posterior crossbite occurs. So it is a clinical finding generally in children with prolonged sucking, particularly thumb sucking. And thumb sucking habit, posterior crossbite occurs due to. So why? Loss of normal outward thrust of the tongue, negative pressure within the oral cavity which causes the buccinator to force the maxilla and molar palatally. A and B, loss of oral seal. Okay. So posterior crossbite is something which occurs only in prolonged thumb sucking, a long duration of the particular habit. So normal outward thrust of the tongue. Tongue is usually associated with the lower mandible, but here we are talking about maxillary constriction. And negative pressure within the oral cavity because of the suction provided by the thumb finger, right? And which will also enable the muscle associated with it to act on it. Answer is C, both A and B. Because a normal outward thrust of the tongue, though it is placed on the mandible, it also has its effect on the maxilla. And when the maxilla is constricted because of the buccinator and other muscle associated with it, it may also lead to the posterior crossbite. So the option is A and B. So both a negative pressure and the normal outward thrust of the tongue is responsible for the crossbite. So, with respect to the tongue positioning, tongue is generally pushed downward and backward, which can lead to the decrease in the thrust of the tongue. This usually results in the narrowing of the upper jaw and thereby increasing in the arch height, leading to a constricted maxilla. Okay, and also negative pressure is created because of an thumb sucking habit, which may lead to the buccinator muscle to force the upper molar towards the palate and thereby constricting it. So we now understand two important aspects. One, the position of tongue is very important in understanding the posterior crust bite because the thrust of the tongue is decreased. Secondly, it is the constriction of maxilla is usually associated with the suction habit, which is due to the thumb sucking, and also by the buccinator muscle, which will push the molars palatally. Okay, these two concepts don't forget. The digit sucking habit in a 5-year-old child should be treated by. So, how we can treat it? So, see, the key word here is a 5-year-old. Okay, we've understood that till 4 years, thumb sucking is very common. So, it's either psychological therapy, reminder therapy, mechanical appliance like habit breaking appliance, and all of these. So the answer is psychological therapy because he's just 1 year past the age where he has to give up on thumb sucking or digit sucking, right? So first we'll start with psychological therapy. So the treatment for 5-year-old also depends on the severity of the malocclusion and severity of the habit. But generally we start with psychological therapy and then we go to the reminder therapy and then finally we come to the mechanical appliance like habit breaking appliance. Psychological therapy is just usually counseling of the child and telling him about the harmful effects of digital sucking. And sometimes positive reinforcements like reward based reinforcements will be very helpful. Reminder therapy means using bitter tasting nail polish or thumb guards that whenever they take it in, they would understand, okay, this is bad. So that is reminder therapy. And finally, mechanical appliance like habit breaking appliance can be used in the intraoral cavity to prevent the child from getting it inside. So, just as a barrier between the hand and the mouth. In a 5-year-old, I think psychological therapy is usually the first line of treatment and it's usually associated with an elder child so that they'll show the elder child is not doing the habit anymore. So, they should also stop their habit. Like, tell should do technique can also be useful in this case. A child is a 7-year-old with a skeletal class 1 relation. He has a habit of thumb sucking. There is a slight overjet and anterior spacing. If he discontinues the habit, okay. So now they're talking about what will happen if he discontinues the habit now. So overjet will reduce. Overjet increases as permanent canines erupt. Lower incisors incline labially, result in the crowding of the anterior teeth. So it is 2 years more than the original thumb sucking. First point. Secondly, already he has a slight overjet and anterior spacing. So this anterior spacing is associated with ugly duckling stage, right? So since he is 7, his permanent canine would not have erupted yet. So we have to wait for it. Answer is A. The overjet will obviously reduce if he stops his thumb sucking. Already there is space for the canine to extrude into the oral cavity. So always think about the age of the patient and the age of the tooth eruption in associated with the given condition and then find the answer associated with it. Generally, it's an ugly duckling state, so a slight spacing is quite normal. Inclination of upper incisors may improve, reducing the overjet further. However, if the habit only continues, then it will worsen the scenario. It is actually possible for lower incisors to incline lingually and for crowding to occur in the anterior teeth because of the pressure from the thumb. But these effects are less likely to occur in a class 1 with mild malocclusion. So skeletal class 1 is also another key word to be noted here. Whatever they've said is also possible, but it also needs a skeletal component to it to worsen it. Since the skeletal component is normal, then we can go for this option. The next question is the abnormal muscular activity usually is the result of. So we are talking about muscular activity. Why muscular activity is coming in here? It can either be because of bruxism. Bruxism is the clenching of the teeth together, nail biting, tongue thrusting, and thumb sucking. So in which is associated with muscular activity, as we already seen, it's thumb sucking. The associated muscle is buccinator muscle. Yes, because as we've already seen, only up to 4 years the thumb sucking is very common, and above which psychological counseling or reminder therapy or mechanical appliances should be given to prevent it. So, bruxism is a parafunctional habit which is categorized by the grinding or clenching of the teeth, and nail biting is a nervous habit, right? And tongue thrusting is an abnormal oral habit in which tongue is brought forward repeatedly. So all these habits can lead to abnormal muscular activity, but they do not directly cause mallocclusion like thumb sucking does. So since eventually all these mallocclusions will result in a muscular activity, but the main thing is thumb sucking. So untrue about tongue thrusting. The tongue thrust develops as a functional adaptation in the anterior open bite. Tongue thrust may not all times result in malocclusion. All anterior open bites are the results of tongue thrust. This habit decreases with age. So all anterior open bites are the results of tongue thrust. That is false because it can be vice versa, but anterior open bite can be because of a lot of reasons. It cannot mainly only because of tongue thrust. Okay, so we should understand everything else is related with the tongue thrust. So tongue thrusting is generally placing the tongue between the upper and the lower jaw in order to make a seal. However, all anterior open bites are not occurred because of the tongue thrust. It can occur because of overly extruded posterior teeth so that the anterior teeth are open condition. They can't meet with each other. And some other habits like thumb sucking or tongue tie can also precipitate this anterior open bite. And tongue thrusting can cause or contribute to a variety of oral facial tissues also, including malocclusion. It can cause speech problems, mouth breathing, and even sleep apnea. It is more common in children, but it can persist in adulthood also if left untreated. So treatment always involves a combination of behavioral modification, oral exercises, and sometimes dental intervention. So we usually associate the patient with a particular dental exercises like ice cream stick exercise, or else we'll ask them to pronounce certain words for a certain period of time in order to adjust the tongue thrust issue. Which of the following habits are most common deleterious in young children? So, which is most common here? Mouth breathing, thumb sucking, tongue thrusting, or nail biting? The answer is thumb sucking is very much commonly found in general population. It's a natural reflex for patients that we've already seen. What is the cause of it and what is the effect of it? It's most common is tongue sucking because that's the way they cope with stress and anxiety. Prolonged thumb sucking can also cause malocclusions like open bite, speech problems, and which may result in mouth breathing also, which may result in sleep apnea conditions. Tongue thrusting is also there, but it is not as common as thumb sucking. And even tongue thrusting can contribute to malocclusion, speech problem, and also may result in mouth breathing and sleep apnea. But nail biting is kind of a psychological issue, and it can contribute to chipped or broken teeth, and also can increase the risk of infections because around the nail bite. Mature swallow pattern is characterized by all of the following. So, except. So, the key word here is except. Relaxation of lips, placement of the tongue behind the maxillary incisors, elevation of mandible until the posterior teeth are in contact, relaxation of the elevator muscles of mandible. So, in order to understand, we have to know what a mature swallow pattern is. It is everything except this. So there is no relaxation of elevator muscles of mandible while we swallow maturely. So the mature swallow pattern, also known as the normal swallow pattern, is a complex coordinated movement, as we all know, including the lips, tongue, and the mandible, and other muscular structures associated with it. So it starts with these steps. First one is the relaxation of lip. The lips should be relaxed, closed position. Second, the tongue should be placed behind the maxillary incisors, and the tongue should rest on the roof of the mouth while swallowing and pushing against during the swallowing process. Third will be elevation of mandible until the posterior teeth are in contact, and forward during the swallowing while the back teeth are in contact. So the mandibular elevation takes place during the process of swallowing. First, the anterior teeth will be in contact and the posterior teeth will be in contact. And finally, the relaxation of elevator muscles of the mandible. This statement is actually incorrect because the elevator muscles of mandible, like masseter and temporalis, are actually activated during swallowing that helps in elevating the mandible and bring the teeth into contact. So the relaxation of the elevator muscles is wrong. It's actually constricted. The muscles involved are temporalis and the masseter. We have to understand this, and we have to understand the process it takes place so that we can answer any more MCQs associated with it. Treatment for abnormal swallow patterns. What they can include behavior modifications or oral exercises, and sometimes orthodontic intervention is necessary. So many times, abnormal swallow patterns may be a sign of underlying neurological conditions or tongue tie, or further evaluations may be necessary to identify the problem and give the proper solution. So, which of the following is not a feature of simple tongue thrust swallowing? Contraction of facial muscle, contraction of mandibular elevators, teeth apart swallow, and anterior open bite. So the question is not a feature. So teeth apart swallow is not a feature, but remaining contraction of facial muscle, contraction of elevators, like we discussed, temporalis and masseter, and anterior open bite. These are all the feature of simple tongue thrust swallowing. So usually, simple tongue thrust swallowing will include contraction of facial muscle. It may tense in this area. Contraction of mandible elevators, because they need to elevate the mandible, therefore they contract. Anterior open bite, they may contribute to an anterior open bite when there is a gap between upper and lower front in the front. So the facts associated with this MCQ is that simple tongue thrust swallowing is most common in infants and young children and tends to decrease with age as children develop. And also treatment involves behavior modification, oral exercises, and very rarely orthodontic intervention. In some cases, this may also be a reason for something underlying condition like a neurological or a tongue tie. The teeth apart swallows usually a normal component of mature swallow pattern. So teeth apart swallow is good. It is associated with a mature adult swallow pattern. Which of the following are not associated with complex tongue thrusting activity? The keyword is not. So, nasorespiratory distress, contraction of the temporalis muscle, contraction of the mentalis and lower lip during swallow, absence of contact of teeth during the swallow. So the answer is contraction of temporalis muscle, because we've seen that in simple tongue thrusting activity, there is a contraction of the mandibular elevators. So since temporalis is being a mandibular elevator muscle, it is associated with the simple tongue thrusting activity and not complex. So in complex, we have nasorespiratory distress, contraction of mentalis and lower lip during swallow, and also absence of contact of teeth during swallow. Yes. So the complex tongue thrusting activity is usually associated with oropharyngeal or neuromuscular disorders, and as well as some cleft palate or missing teeth. So generally the features include nasorespiratory distress. It may cause or contribute to difficulty in breathing. Contraction of mentalis. So muscles of chin and lower lip may actually tense or contract during the swallowing, which may lead to other malocclusions or orofacial issues. Absence of contact of teeth during swallow. So they also contribute to anterior open bite. So the important fact is that it is often associated with oropharyngeal or neuromuscular disorder, that is the complex tongue thrust. A temporalis is usually not associated with complex tongue thrusting activity. Instead, it is associated with a simple tongue thrusting activity. So the abnormal swallowing pattern with the poor um, how it is characterized, it is actually characterized by pushing forward or between the teeth during swallowing, similar to simple tongue thrust swallowing only, just pushing the tongue outside. And but however, unlike simple tongue thrust swallowing, a retained infantile swallow, it does not improve with age or disappear on its own. It actually persists and makes things bad. This can contribute to malocclusion and other orofacial issues. So the important aspect here is simple tongue thrust swallowing is an abnormal swallow pattern that is mostly present in infant and young children, but it tends to decrease with age as children develop a more mature swallow pattern. When it comes to retained infantile swallow, that is bad and it has a poorest prognosis. Yes. Treatment for that would be behavior modification, oral exercises, and sometimes orthodontic intervention is also necessary. So, which of the following describes complex open bite? It is an anterior open bite with well-defined opening in the beginning. There is an occlusal derangement and occlusal equilibration is mandatory. Usually, it is associated with thumb sucking habit. So, which of it is a? It's not generally open bite. They've given complex open bite. So it is only an occlusal dearrangement and occlusal equilibration is mandatory. That is the answer for it. Let us understand why. So what is complex open bite? It is generally a type of open bite, but it's most severe in the occlusal disturbances and also the skeletal disturbances when compared to the normal open bite. It can be because of habits like thumb sucking, tongue thrusting, or other oral habit, and also because of underlying skeletal conditions. So, what is very important in a complex open bite? The anterior teeth do not come in contact when the patient bites. Therefore, there will be a space between the upper and lower teeth, right? So, this can cause functional and also aesthetic problems. So, since they can't meet it, they can't chew the food properly. There will be a functional disturbance. They can't speak properly. The tongue won't be in the position to make similar sounds, and they'll have asymmetry. So this treatment includes a multidisciplinary approach. It requires an orthodontic intervention, surgical intervention, and other speech intervention in order to correct it. This occlusal equilibration or reshaping of the teeth to achieve proper occlusion can also be essential in certain cases. So, what are the facts associated with this? Open bite is a type of malocclusion, which is generally lack of vertical overlap in the anterior region. Simple may be in the mild form, wherein it affects only the front teeth. But complex, it may have a lot of problems underneath. It may be skeletal, or it may be because of a prolonged habit, or it may be because of an occlusal derangement, which would need a balancing equilibration in order to bring it into normal. And it also includes a multidisciplinary approach. Orthodontic and surgical intervention is necessary. So the number of times an individual swallows per day, it's very easy question. It's 800. The number of times an individual swallows per day while being awake. So here the keyword is awake. So it's a complex process. We all know what a swallowing is, and the answer is 800. Mouth breathing with enlarged adenoids and tonsils may be best described as. So here, mouth breathing is a habit because of which the adenoids are enlarged. So it it cannot be anatomic. It can either be obstructive, physiological, or habitual. So it is obstructive. Why? Mouth breathing always results in an enlarged adenoids or tonsils. It's described as an obstructive because this enlarged adenoids in turn can block the airway, making it difficult to breathe through the nose. And this obstruction can also lead to mouth breathing, which may affect the sleep quality, and thereby it's obstructive. We have to understand what it affects rather than what it gives. So, mouth breathing, it may lead to obstructive scenario because of enlarged adenoids, which will restrict the airway into the lungs. So obstructive sleep apnea is one of a condition associated with mouth breathing habit, which results in a repeated episodes of partial or complete upper airway obstruction during sleep. And in children, this obstructive sleep apnea can lead to very much behavioral problem because of improper sleep and lead to hyperactivity, poor performances, as well as growth and developmental issue. The children's sleep is really important. When it is prevented, then they can show up a lot of psychological stress. So, what are the preventing measures? It can be orthodontic or myofunctional therapy. Nasal breathing exercises can be given, or breathing devices can be given to them in order to reduce the orthodontic sleep apnea. Lifestyle modification can also be done. So, high fact is that mouth breathing is sometimes or most of the time associated with enlarged adenoids and tonsil. Is best described as obstructive mechanism. And this enlarged adenoids and tonsil can block the airway, making it difficult to breathe through the nose. And it is also invariably associated with obstructive sleep apnea. So, treatment of obstructive mouth breathing may be a removal of adenoids and tonsil as well as orthodontic and myofunctional therapy. So, the effect of enlarged adenoids on the maxillary growth or mouth breathing habit usually causes what? So, what happens when there is an enlarged adenoid? Narrowing of maxilla, widening of maxilla, palatal plane tipped upwards. If this is the palatal plane, what they are saying is it's tipped upwards and palatal plane descends down. So here the answer is narrowing of the maxilla. So the enlarged adenoids on the maxilla, it's growing like this because of which the maxilla is constricted. Now let us see why. The maxilla, which plays an important role, okay, in the development of face and also the airway. So the children breathe through their mouth because of enlarged adenoids. The other reason can affect the development of maxilla. Because when they're not breathing through their nose, then the maxilla also the development will be poor. When they breathe through their mouth, it may invariably affect the maxillary growth and thereby it leads to constriction of maxilla. So children with enlarged adenoids tend to have narrow maxilla than the children without the adenoid problem. Important to address an enlarged adenoid. Which of the following is not a feature of long-standing mouth breathing habit? So adenoid facies, large nose, upper anterior labial gingivitis, and frequent occurrence of tonsillitis, allergic rhinitis, and otitis media. So we have to find out which is not a feature of long-standing mouth breathing. The answer is B. Large nose is not a mouth breathing habit because it doesn't really make sense. Adenoid facies, yeah, it makes sense because the adenoid is increased in mouth breathing patients and it may also lead to upper anterior labial gingivitis. Since they are constantly exposing to air, there may be an labial gingivitis occurring in these patients and frequent occurrence of tonsillitis and allergic rhinitis and otitis media. Constant opening of the mouth and allowing the air to pass through them. They won't go through the nose, which has some ability to filter the air. So since it goes through the mouth, they have no ability to filter the air, and thereby the tonsil easily gets infected. Even the ear is associated with it and get easily infected. So all these conditions are directly associated with mouth breathing, except large nose. Yes. Chronic mouth breathing can cause dryness of oral cavity, which may lead to gingivitis. And frequent occurrence is because of the inflammation of the tonsil and infection of the middle ear. So breathing is termed anatomic mouth breathing if there is short upper lip, enlarged adenoid, enlarged tonsil, and both A and B. So here the key word is anatomic mouth breathing. So breathing is termed as anatomic because only when there is a anatomic body part associated with it, that is short upper lip. So with this 1000th question, we'll come to the end of today's session. So today we've majorly discussed about Yeah. So today we majorly discussed about anchorage, mainly tats, and then we've concentrated on some habits like thumb sucking habit, tongue thrusting, and also mouth breathing. Tomorrow we'll continue with the class. And if you have any doubts or questions, kindly put up in the comment box. And if you need any assistance and if you have any doubts during the previous sessions that you want to continue, you can definitely put up in the comments. I will address it at the end of each session. Thank you and hopefully waiting for tomorrow's session. Bye and have a good night.